Um, I went through all the notes that I made throughout the week. I went through the chairperson's comments, and I went through Ezequiel's diaries. One of the things, Nan and I did this together, and one of the things we realized is that there's no way we can do it justice to try and say what has been accomplished, what are the things we've talked about, and give anything like the depth that is needed to summarize this meeting in the few minutes that we have now. What we did note are a few highlights. So the reason I'm saying this is so that we're all clear that there's no way we can provide a comprehensive review, nor are we going to do justice. There are many things that were said, many very rich conversations that will not be captured here. But what I'd like to do is to take us through the key points that we have gone over, some of them at least, at some superficial level, just to remind us, recap what we've done up till now in this seminar, and prepare us for developing our statements. With that, let me start by saying that the meeting started off as a venue to set an agenda for healthcare improvement in the coming years. We know that we've gotten we've come a long way in terms of making healthcare better. There's a lot to be learned. There's a good amount of scale-up happening, even more to be learned there. And that what we would like to do is to formulate directions for ourselves that would take this important work that's been accomplished today to another level and get us going in the next 5 to 10 years. As such, this seminar is really only the beginning of a journey. It's not the end of the journey. So what we will do is we will take the work that we've accomplished in the seminar and use it in other work that we're doing and in promoting the direction that has really yielded so many of the good things that you've shared with us. One of the key issues that seems to come up in this, which we elaborated in the framework paper, is that there are a lot of known interventions that are not reaching every patient every time it's needed. And the problem isn't in the lack of those interventions. The problem is in the inability of healthcare delivery systems to implement these interventions reliably every time they are needed. For that, we need to be doing something a little bit different than just the content pieces, the interventions themselves. This is manifesting itself very well in the Millennium Development Goal targets. We know that many countries are off track. For example, we talked about only 23 countries for reaching or possibly reaching the maternal mortality Millennium Development Goal target of 75% reduction by the year 2015. There's a lot of work to be done. We looked at the challenges that are yielding this picture. There were many challenges. Of those, 5 were identified as priority challenges. At the top of the list came human resources as a major challenge. This is not only about inadequate numbers of health workers. It's not just about the high turnover, the maldistribution that we're seeing in many places. It's also related to skills, continuing medical education. It's related to morale. And we need to be addressing all of those issues in order to go forward. Community involvement was highlighted as a key challenge. And more civil society engagement in healthcare was recognized as one of the key issues that needs to be happening in order for healthcare to become better. This requires advocacy, this requires engagement with the public. This requires getting feedback and being responsive to the communities that we are serving. Poor planning came up as a challenge. With poor planning, we talked about the issue of verticalization of certain programs and the fact that these vertical programs are oftentimes not integrated enough to be able to accomplish all the good results that they could possibly be accomplishing. And then focusing all this work to meet the patient's preferences and the patient's needs. And we had a lot of debate about that, and about, rightly, Rubina pointed out to us that sometimes the knowledge base is not there, and we went into quite some depth on that. But a very enlightening conversation wonderfully took place during the seminar because we had Rubina and her insights into this process. And then there's all the different perceptions of quality amongst different stakeholders, between policymakers, providers, patients, other key stakeholders, and how everybody sees things in a different way. Key challenges, and many more key challenges that we need to be thinking about as we take improving healthcare to the next level. There's key issues of confusion. The confusion has revolved around a lot of terminology, jargon terminology, a lot of acronyms, most of those describing quite similar things, methods that have little twists from one to the other. It's bad enough that the generic science has a lot of, or the generic names for the approaches are too many and not necessarily all justified as different things. We are also faced with all of the brand names that have come in and taken those and have spun them in different ways. One of the things that we came out with is that we really do need to address the issue of confusion. We need to make things simple, make it easy for our colleagues in the field of healthcare to get their heads around what's going on and how they can use it to improve healthcare. Other specific issues that came up included documentation, the need for accurate, correct documentation, particularly at the health service delivery level. That's where it starts. If we can get the right data there, and then aggregation and analysis and others can take place differently. Knowledge sharing was a major theme. And this is not only about what interventions are known to work, but about the know-how on how to implement these interventions in real life. That is a whole other area of knowledge, equally important, if not even more important, than the content knowledge itself, which we very often share and is more available than that particular know-how on how to make them happen in real life. A major topic of conversation was research and evaluation. And we talked about research that is critical to support all the different approaches and techniques that we are using, to understand them more fully, to be able to use them in better ways. We talked about data that needs to be simple in order for it to be usable to drive improvement in a different direction. We talked about the need to do a lot more cost-effectiveness analysis of the work that we are doing. We need to have documented evaluation experiences and mainstream this approach as part of healthcare globally. We talked about research related to scale-up and how in scale-up we need to ensure commitment, community involvement, and the planning of scale-up efforts. And we need to study those in order to be able to take this to the next level. A major topic of conversation was strengthening health systems. And here we had a review of the World Health Organization's 6 building blocks. We looked at them We looked at various efforts underway, the types of activities that strengthen health systems. We looked at the role of QI in strengthening health systems as being a dual role of not only tackling the bottlenecks, the key areas of weakness within each of the building blocks, but also coordinating and streamlining the interactions between those building blocks. Michelle took us through the use of incentives in order to make healthcare better, a very enlightening approach and experience from Belize. Leadership was a main theme, and it came up not only in the section on leadership, it also came up throughout our discussion. With every conversation it was coming up, this is one of the most critical ingredients for the success of this work. We know that. However, leadership is very vaguely defined. We're not very clear on what we mean sometimes by that. We had good debate on what constitutes good leadership, what are the ingredients that are needed. One of the things that came up here is the need to implement the work at all levels in the system, involving leaders at the different levels, be them national, regional, provincial, district levels, community levels, all of whom need to get together in order to be able to do this, and nurturing leadership at all of those levels as being a key component. One of the big insights that I think came out from this meeting is that we need to be targeting leaders that are tightly connected with their communities. These are people who represent the communities or the people that they serve. They're with them, and they can truly be leading these efforts and producing the successes that we need. In targeting these leaders, we need to be looking at their involvement from the get-go, if not their total ownership of this work, together with the people that they serve, the communities and the health workers that are involved in this process. This moved us out of this whole realm of, we do something, prove that it's good. No, engagement of leaders needs to happen from the get-go. The engagement of civil society, community, patients in the improvement initiatives was also seen to be a critical component. Capacity building in the health system in such a way that enables this good work to continue independent of external assistance was pointed out as a key leadership function that we would like to see in these systems. When we talked about execution, 8 key drivers came out of that conversation. And the drivers for good execution on improvement work were the following. Communities and patients who really create the demand for this work, and without whom this work probably would not be successful. The health managers, the providers, the professional societies, the people who are engaged in the work of caring for the patients and the communities that they serve. The data systems that are needed to drive this and to be able to see what's happening, understand it fully, see the successes or lack thereof, and be able to adjust accordingly. Capacitating the frontline health professionals and managers and leaders in the system in the improvement methods was seen as another key driver. Another one was political buy-in for improvement. Another was support from external funders. And then the role that improvement experts, be them from within the organization or from outside of the organization, provide to this process as a key driver for successful execution on this. And then we talked about the evidence base for using QI methods. The evidence base being what do we know that works, how does it work, what methods are good where, and the like. Important drivers for successful execution on improvement. We then went on to address the learning agenda, a major topic. In order to evolve this field, we need to learn about this field. We need to learn about not only the successes, more importantly the failures. Why did something not work? That came up as another key issue here. And this is not only about the research that we need to do in order to learn, but it's also about how we capture the knowledge that's happening anyway by virtue of us doing the work in order to learn from it. Within that, we talked about a number of interlinked constituencies, and those included communities and patients who understand their rights, their role in driving the healthcare improvement agenda. We talked about technical advisors who have a major role in promoting improvement as a method for getting better healthcare outcomes, have a responsibility for accurately collecting, synthesizing, disseminating data and information related to furthering the improvement agenda. We talked about the leaders of the health system and their role in promoting the agenda for including improvement as part of the national strategy, and how they can use that information and that agenda to improve outcomes and look at cost savings where that is possible. Another constituency was the national and global academic communities. The main interest here is impact data, cost effectiveness data that would influence and promote the use of this evidence to support the improvement efforts. And then the last constituency was the global health policymakers. Again, within this, we talked about many aspects of using simplified descriptions to convey the message about what improvement is, what it does, how can it be effective. We talked about the need to show not only better outcomes, but also the cost effectiveness of this, as well as return on investment where possible and improved efficiencies of healthcare systems as a result of using that. Jim shared the vision with us at the end of that session, the vision of a dream quality improvement database that basically can help us move in a different direction. I think the way he described it was, imagine if somebody wanted to find out about a topic, put in a query, and all of a sudden he had, in a standardized format, a number of descriptions in different languages where he can find out not only where things happened, who did them, what were the results, what were the interventions, but also the contact information, how to get in touch with people to ask more, and where we would be if that were to exist. I think it's a vision that's worth pursuing. On a personal note, I've gotten to learn a lot about the area of knowledge management in the last couple of years. And one of the things that became so apparent to me is that it is not enough to emphasize the collecting part of the knowledge management process, that is capturing the information, putting it in the right formats, etc. More important is the connecting part. So as opposed to pure collecting, connecting people, because knowledge is generated in the moment through human interaction, and the ability of people to pull this up, see if this is what they want or not, and then to be able to connect to the people who did this and interact with them and figure out that information that they need is going to be of the essence. Now, let me again say what I started off with, which is I haven't done justice to a week's worth of work in 15 minutes. There's no way I can do that. There are many things I've missed out, and please forgive me for missing out key things that are on the top of your mind. But we did try to put some overarching themes, put some things that would get us started today on developing our Salzburg statements. And what we're also doing is making these in a minute available to you so that you can refer to them as we go into the development of the statements themselves. Let me now just for a moment say something about the statement. The statement is a key product of this meeting, and I'd like you to just, as you're developing it, keep in mind that it's not just an academic exercise we're doing here or a nice exercise that we're going through. This statement will reflect what we have accomplished, and it will encapsulate our recommendations, our aspirations for where we would like this field to go. We will address it to all the key stakeholders that we can think of, with different language for each one of them. And we will take this statement to many places. We have a number of venues where this is going, not least of which is a report out at the World Health Assembly. Our colleagues from the World Health Organization have already organized that. And so this statement will reach many, many people and will have a lot of impact on them. It will also be the basis for a lot of the publications that we're going to have related to this seminar. And I hope each one of you will take this statement home and work with it and take it to your ministries of health, take it to your colleagues and friends, and use that as a basis to move the field forward. I want to thank you very much and look forward to bringing today to a real grand finale with you. Thank you.